Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on Public Health Nurse-Delivered Group Cognitive Behavioral Therapy for Postpartum Depression. My name is Sarah Carsley, and I'm the Applied Public Health Science Specialist in Healthy Growth and Development here at PHO, and I have the pleasure of moderating today's session. Before we begin with today's presentation, I'd like to acknowledge that I am in Toronto, on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties, signed with multiple Mississaugas and Chippewa bands. A few housekeeping items before we begin. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as moderator of this session, I do not have any potential conflicts of interest to declare. It's now my pleasure to introduce the speakers for today's presentation, Dr. Ryan Van Lieshout, Amanda Hicks, and Christina Bradley. Dr. Ryan Van Lieshout is a psychiatrist and clinical epidemiologist at McMaster University, interested in developing and testing interventions aimed at improving access to care for birthing parents struggling with postpartum depression. This work also examines the impact of these interventions on infant neurodevelopment and subsequent psychiatric risks. Amanda Hicks is a public health nurse and program manager in the Family Health Division at Niagara Region Public Health. And Christina Bradley is a public health nurse and lactation consultant at Niagara Region Public Health, focusing on family support through outreach services. Thank you all for being here today, and I will pass it over to Amanda.
Thank you for the introduction, Sarah. It's nice to see that we have such a great turnout and interest in this topic and an opportunity to share with you our learnings. So by the end of the session, we're hoping that you'll be able to describe the prevalence and impact of postpartum depression on birthing parents and families, understand the treatment effects public health nurse delivered group cognitive behavioral therapy for postpartum depression has on maternal depression, anxiety, and the mother-infant relationship, describe the potential benefits of cognitive behavioral therapy training for public health nurses beyond the group alone, and understand how evidence-based public health interventions can be collaboratively integrated into practice beyond the research phase. I did want to make just a disclosure here that we haven't included findings or our study of the virtual delivery of PHN-delivered cognitive behavioral therapy for postpartum depression, but we can answer questions about the virtual delivery when we have the Q&A period, because we have had some experience now through the pandemic with delivering this intervention virtually. I'm going to pass things to Dr. Van Lieshout, and he is going to take us through the technical aspects of the study we're here to talk about today and the findings.
Thanks, Amanda. I'm really excited to be here today and to share with everyone the findings of this wonderful collaboration that we've had going with Niagara Region Public Health for the past several years. So I'm a psychiatrist at McMaster University, and many years ago, one of the public health nurses came up to me after a presentation I'd given in a public forum, and said, if we had no money, how could we really serve clients with postpartum depression well? And I said, well, it might be a nice thing to do to develop a CBT group for postpartum depression. And her name was Carolyn Bath, and she and I started on the path along with some other collaborators to launch this several years ago. So we're going to talk today. We're going to talk a bit first about postpartum depression, its scope, and the need for treatment for these individuals. We're going to talk a bit about the concept of task shifting, and then we're going to describe the findings of the randomized control trial of public health nurse delivered group cognitive behavioral therapy for postpartum depression. We did a complementary qualitative study with the nurses that delivered the groups, one of which is Christina Bradley, who's one of the presenters today, and she's going to talk to you a bit about the impact that the training and the delivery of the intervention had on the nurses in both their professional and personal lives. And then Amanda is going to walk us through a very exciting development, and that is the translation of this intervention into real practice, and showing that we can develop things together, collaborate, study it, and then launch it here in Ontario. So people are probably here because they know that postpartum depression is a massive public health problem. In fact, it affects up to 1 in 5 mothers and birthing parents. And it's associated, one of the reasons I think it's interesting from a public health perspective is that it not only affects the mothers, but it can also affect and birthing parents, but also the offspring. So in the birthing parents, it can increase the risk of later depressive episodes, problems with their relationship with their partner if they have one, and cognitive, emotional, and behavioral problems in offspring. And in 2014, Bauer and colleagues did an analysis of the costs of postpartum depression across the lifespan, and said that it cost about $100,000 per case, so about $1.4 billion for every year's cohort of births in the province of Ontario. One of the most striking challenges facing individuals with postpartum depression today is that just 1 in 8 to 1 in 10 of them can access evidence-based care, and that is the impetus for us developing this intervention. We partnered with Niagara Region Public Health for a variety of reasons. They were excited about the idea. They were innovative and forward thinking when we talked about it, and because it's a region that where there is a higher prevalence of mental health struggles perhaps than other areas of the province. In fact, when clients were surveyed in 2019, they reported that 31.6% of those living in Niagara that themselves or their partner had a history of mental illness, and that compared to about 20% in the rest of the province, and that rate was similar in 2020 as well. So we knew that there was a lot of need in the province. Now, in terms of accessing care, there are a lot of barriers that exist. We don't have time to go through all of them. Obviously in the postpartum period, there are concerns about antidepressant use during lactation, and a lot of individuals prefer talking therapies or psychotherapies. And then the problem with that, of course, is that there are really long wait lists for OHIP insured services and psychotherapy. And the Ontario Structured Psychotherapy Program hopefully will start to reduce some of these waits, but we'll have to see how that plays out, and if our clients or if people with postpartum or perinatal mental health problems are prioritized in any way. So given the traditional healthcare systems struggle with adequately serving these individuals, we have to think of creative ways to try to meet these needs. And one of these ways is to think about using task shifting. So task shifting or task sharing is the process of delegation whereby services are moved from more specialized experts who cost more, like me, to those who have less training and presumably less cost, like public health nurses, people who've recovered from postpartum depression, and so forth. Postpartum depression is ideal for task shifting for a variety of reasons, not the least of which is the fact that structured psychotherapies can be delivered, have been shown to be able to be delivered effectively by those without tons and tons of extra training. And so we thought it was a great opportunity to do that. On top of this, public health nurses are I think we thought, the perfect group of professionals to task shift the delivery of evidence-based psychotherapies to. A variety of reasons for that. Public health nurses are often a first point of contact for those with postpartum depression and end up providing care anyways. When we ask birthing parents, moms and birthing parents, what they prefer, RNs are the preferred non-specialist provider of psychotherapies for postpartum depression. So I was going to say you guys, but nurses are preferred by those who are struggling. In the province of Ontario, registered nurses are one of the 5 colleges that can deliver the controlled act of psychotherapy. And if you ask public health nurses what they think in general, they think that if they're going to be working with individuals with postpartum depression, that their role should also involve management, including counseling interventions. So we have a big need, and we have a creative solution, and we have a great group of people who could deliver it. Now we just have to see how that goes. So, in the past, there have been studies of nurses delivering psychotherapy to clients with postpartum depression. But the majority of those studies have used highly trained RNs, highly trained in a psychiatric sense. So individuals who've had lots of training in psychiatry, in the delivery of psychiatric interventions and psychotherapies. The majority of the studies that have involved nurses delivering psychotherapy to those with postpartum depression have been have been in an individual setting. That is, one nurse to one client in their home or at the clinic and so forth. So a little less efficient than is ideal, but they've been effective. But it's been delivered on an individual basis. Only one study looked at nurses delivering a group therapy. It was more of a supportive intervention, but those nurses had a lot of previous psychiatric training. So what we were excited to explore was whether the nurses could deliver group CBT for postpartum depression. So as many of you will know, cognitive behavioral therapy is an evidence-based treatment for postpartum depression. It's been around since, well, for 60 or 70 years now. It's a structured therapy. It's a short-term therapy, 12 to 15 sessions. Our intervention was nine sessions. It's structured and it's manualizable. So that can help with fidelity. And so it makes it ideal for not only task shifting, but also potentially scaling. And CBT delivered in groups over individually is more cost-effective, thought to be equally clinically effective, and has the potential to treat more mothers and is more scalable. So that's why we proceeded with a group model. So given this background, we were interested in determining if RNs in public health settings, so public health nurses, with no prior extensive formal psychiatric training, could deliver effective group CBT for postpartum depression. We're also interested, as we mentioned earlier, assessing the impact of the training and delivery on the nurses themselves, just to make sure that it wasn't overly burdensome to them or it didn't cause problems. And then we wanted to see if the treatment was effective, if we could start to translate it into practice and think about scaling it. So now I'm going to talk to you about the randomized control trial that we did. So in this study, we randomized 171 mothers and birthing parents who were over the age of 18 and had infants less than 12 months old, and who had an Edinburgh postnatal depression scale score of 10 or more. We took those moms and randomized them into one of two groups. They either were randomized into the treatment group, where they got the 9-week group CBT for postpartum depression delivered by public health nurses, on top of treatment as usual, so they could access treatment from their family doctor, obstetrician, midwife, therapist, anyone else. So, and we either randomized them to that treatment group, or they were assigned to the control group. And the control group could receive treatment as usual from their family doctor, therapist, midwives, and anyone else. So the only difference between the two groups was this 9-week public health nurse delivered CBT intervention. We examined the participants at baseline, immediately after the treatment, and then we looked at their outcomes 6 months later to see if the gains were stable and continued. We looked at a variety of different clinical outcomes. Today, we're going to talk about the impact on depression, anxiety or worry, social support, and the mother-infant relationship. We also examined the impact on infant neurodevelopment and emotion regulatory capacity, but hopefully we'll be able to present that at a future talk. So here's a little bit about our sample. We randomized 141 mothers and birthing parents, as we mentioned, 70 to the treatment group, 71 to the control group. They were about 31 years old on average. Their infants were about 5.5 months old at enrollment. Most were married, and almost all had graduated high school, and the household income was not near the low income cutoff. It was about $80,000 before tax per year. About 30% were taking an antidepressant, and an important thing to note is that about 2/3 of them, 67%, 66%, had a diagnosis of major depressive disorder. So they had current major depressive disorder. You'll have noted that our eligibility criteria was an EPDS score of 10 or more, and about 2/3 of those individuals had a diagnosis of major depressive disorder. So they had substantial symptoms. So as we get into the results of, we're excited. So this is where things I hope get exciting, even more exciting for people. So when we look at the Edinburgh Postnatal Depression Scale score, the first thing that you'll want to note is the solid line is the treatment group, the hashed or dotted line is the control group. And you'll see that they started about the same point as they should in randomized controlled trials. And we found that at 9 weeks of follow-up, so immediately post-treatment, there was a clinically and statistically significant improvement in the treatment group over the control group. So those who got the 9-week treatment did better. And I mentioned that it was clinically significant because the improvement was more than 5 points, it was 5.25 points. And a clinically significant improvement on the EPDS is 4 points. So we were well above that mark. And as we look out to 6 months, that's the third time point we're looking at there, way out to the right. We see not only were these gains, did these gains continue, not only did these gains persist, but they continued. And we see that the average score in the treatment group is below the 10-point cutoff. So we'll go to the next slide to look at provide a bit more detail. So when we dichotomize the outcomes and said how many in the treatment group, that's the gray group, how many of them experienced a clinically significant improvement, so more than 4-point improvement on the EPDS, we saw that 63.5% of the moms in the treatment group that got the public health nurse delivered CBT for PPD, 63% had a clinically significant improvement compared to 33% in the control group. So they were 3.5 times more likely to experience a clinically significant improvement, and the number needed to treat is about 3. So the number needed to treat is the number of extra individuals that you need to treat above and beyond the control condition to get a positive outcome. So that means that if we treat 3 more moms, one of them is going to have a positive outcome compared to treatment as usual. So this is a very nice, a perfect number needed to treat is 1. So this is a nice number. So if you're not swayed by 4 points on the EPDS, let's talk about what happened when we looked at current major depressive disorder. So we did a structured interview with the participants. We used the mini international neuropsychiatric interview, and we see at baseline on the left there, the blue group is the control group, the gray group is the treatment group. We see that about 2/3 of the total sample met diagnostic criteria for a full-blown major depressive episode at the time they were enrolled. What we see after treatment, after the 9 weeks of treatment, that the blue group, that's the control group, they were still at 65%. But the proportion of individuals, participants that had major depressive disorder after treatment was about 25%. So the participants in the treatment group were nearly 5.5 times more likely to experience a remission of their depression compared to those in the control group. So most people in this room, if not everyone, knows that anxiety and worry is a common comorbidity of individuals with postpartum depression. About 50% of them will have comorbid anxiety that's clinically meaningful. Again, the treatment group is the solid line. The control group that didn't get the public health nurse delivered intervention is the hash line on top. You see that by the second time point in the middle there, by 9 weeks after treatment, there's been a substantial improvement in the anxiety levels, the worry levels of those in the treatment group. And then this improvement continues out to 6 months follow-up, whereas in the control group, the anxiety and worry levels remain quite consistent and high. We also looked at the mother-infant relationship. We used the postpartum bonding questionnaire to assess this. Because of the scale of the graph that we show here, it looks like the 2 groups are different at baseline. They're not statistically significantly different. And what we see in the solid line is that there was a significant improvement in how the moms rated their own, the mothers and birthing parents rated their own bonding by 9 weeks. And then at 6 months, it continued to improve. We're glad that the control group also improved over time, but the improvement in the treatment group was larger. Another subscale of the postpartum bonding questionnaire is the rejection and pathological anger scale. I think back to when my daughter was little. I think I might have scored a bit high on this one myself. But so what we see here again is the control group, which is the hashed line, the dotted line. They stay roughly consistent, whereas the treatment group, I should say, has improved substantially over time. These differences were statistically significant as well. Finally, the last mother-infant relationship slide is infant-focused anxiety, which was a lot higher during the pandemic. This is a study that was delivered in person prior to the pandemic. In fact, I think we did it right up until everything got shut down, so it was timely. I'm glad we got finished in time, and we see substantial improvements in infant-focused anxiety in the treatment group, not only at 9 weeks, but that persisted out to 6 months postpartum. So as we can see, you know, I wasn't surprised, but I'm glad we did the study anyways. The public health nurses did a remarkable job of delivering group cognitive behavioral therapy for postpartum depression. And as you saw, it not only improved depression a statistically significant amount, but a clinically significant amount. It also improved worry and aspects of the mother-infant relationship. So switching gears a bit, we did a second study, a qualitative study that my friend and colleague Christina Bradley is going to present in a moment. But we spoke with the 6 public health nurses who did the training and delivered the groups, and we talked to them for about an hour each. They were very generous with their time, and we did a semi-structured, in-depth interview to find out how the training went, how delivering the groups went, how the supervision went when we were doing it. And what we did is we used a phenomenological approach. Phenomenology is a qualitative research method. It focuses on summarizing the experiences of a group of people into its universal essence. So what we want to do is find out what a group has in common as they experience a phenomenon. And in this case, the phenomenon was CBT training and the delivery of the groups. Christina.
Thanks, Ryan. So our training was kind of broken down into really 3 stages. So, you know, stage 1, we were given some pre-assigned readings. I was one of the nurses that participated in this original training, as well as in that kind of secondary study. So we did some pre-reading, and then we participated in a 3-day long, you know, training, full day, really focusing on skills. So what is CBT, understanding CBT, how do you apply it into practice, doing some practical like role playing and application during that time, and also taking a look at, you know, how do we navigate, you know, resistance from clients, and how do we overcome that and navigate some of those group dynamics and individual dynamics that might come up during group. Then the second stage was we went in pairs to actually observe the course being delivered within a hospital setting. So the full 9-week series, which was, you know, again, just a great opportunity to take all of that learning and then see it in practice. We were able then, after each session, to then debrief with Ryan, who was one of the facilitators, and really get at some of the nuances that were coming across in groups. And, you know, like, why were things phrased that way? How come you didn't address that? And really get at some of those very practical kind of details in delivering the series. And then we went off in pairs and actually delivered them independently. Now, those first sessions were actually recorded. We got permission and consent to audio record that kind of stage 3 in our training. So we delivered the 2-hour sessions. Those recordings were then, you know, listened to, and weekly we engaged in a 2-hour kind of reflective practice piece in consultation with Ryan to, again, you know, this is a new skill set, right? Like we're nurses who haven't delivered psychotherapy before. So having that reflective practice piece built in to be like, how can we really hone, right, those listening skills, the empathy, right, the core components of CBT, and stick true to that material, stick true to that evidence-based concept, you know, while delivering some potentially, you know, in situations that can be quite emotional for individuals. It also helped us keep to the fidelity and the adherence of that CBT model, and that we were delivering, again, each module consistently and staying true to the concepts of what CBT is. So what we did is the 6 of us, those originally kind of trained nurses, after we started delivering and were, past that stage 3 of our training and delivering independently, we sat down and really kind of explored the impact of what training had on us. How is it impacting us professionally? The delivering of CBT, how is it also affecting us, personally and in our lives as well? And you can see that by some of the questions there on the screen. And it also came down to, was it affecting our quality work, right, our satisfaction and our confidence in addressing postpartum depression with families. So first, some of the professional developments. I have to agree with this kind of conclusions that came and on behalf of my peers, but definitely a lot more confident, not only in delivering CBT and the CBT series, but also with having conversations with moms as they come across our practice. Me, myself, as a lactation consultant, I see a lot of families over the first year and a half of this transition to parenthood, and just my confidence in having conversations with them and feeling empowered to be able to do something to help support them through these moments of transition and postpartum depression was, I think, a huge professional benefit that not only myself, but my peers acknowledged as well, right? It enhanced our skills and how we, took the components of CBT and what we understood about postpartum depression and effectively be able to navigate some of those conversations in other areas of our practice. Definitely a lot more, client-centered approach as well. Some of our programming that we were offering at the time tended to be a little bit unidirectional, right? I have a problem, I come to a nurse, here's my problem, and we jump into that rescue role, right? I've got the information for you, let me fix that, right? I can help with, with your breastfeeding, I can help with your bottle feeding. Oh, your child's not sleeping through the night, let me help with that. And we noticed a shift in our skill set where we were listening more. Right? What really is that client trying to tell me, right? Is it about the sleep or is it about their coping, right? What is getting behind some of these things and getting comfortable with asking questions, right? And being comfortable with asking, and how are you coping with all of this? And letting it organically, be able to kind of explore some of those mental health pieces that come along with this transitional phase in a family's life. Some of the other professional benefits was, recognizing when we're delivering CBT was that clients were there for psychotherapy and they're not there for the parenting information. So again, kind of, turning away from that rescue role. If we had somebody to kind of share in group a situation where they were up all night because baby's not sleeping, they're going through what they would term a sleep regression, and they're having these strong emotions and these thoughts of, I'm a bad mother, I can't do this, right? We're not there to help with sleep in that moment. We're there to help, navigate all those strong emotions and thoughts that come with these moments of parenting and build that skill set for effective coping and management of those depressive symptoms. So we found that, yes, we are as nurses, very compassionate and empathetic individuals, but that really did go up. And, because we were really truly listening to our clients and having these meaningful interactions, our clients were more likely to seek out our services again, or also seek out the services of other healthcare providers because of the dynamic and therapeutic relationship that we were creating. And as a quote from the study, one of my colleagues shared, You know when you should be listening and not giving out information even, because we tend to give as nurses sometimes. You just have to sit back and listen. And I'm more in tune with that role now. Not only did we find that it was, impacting our professional lives, but it was impacting, like, really learning the skill set was affecting us personally as well. Like as a group, we found that we were like coping with challenges at work and in our personal lives much more effectively. We're becoming more active listeners, right? We had definitely improved interpersonal relationships, right? With our family, our friends, our coworkers. And it also, we learned some skills to really set up some of those healthy boundaries as well. We noticed that we were applying one of the core concepts of CBT, which is thought records, and coming up with more perspective and a balanced way of looking at things. We're bringing that into our personal lives. Like the quote below, I realized that I do balanced thought all day long just to get through the day. I've noticed that if I've had something that's just sitting there and I can't get past it and it's bothering me so much, I'll do a thought record. So we were living out what we were teaching in our personal lives. Some of the implications for practice is, we were taking a shift more from, again, what was our kind of our role at the time of providing information to really focus on skill building. And recognizing that's kind of been validated from the research and what we were seeing with clients and seeing them, it's one thing to see the numbers, but being able to see it also CBT as the clients progress through it, seeing the change, right? Seeing the progress, seeing, them feeling and making comments like, I feel like myself again, was a real tribute to, we're focusing on skill building, and these skills we know from CBT last a long time and last beyond the study and are key skills that kind of last a lifetime for these individuals. So we started having conversations that kind of led to this quote, right? You really need to take a look at the future of public health and what our roles are. We have to do more than just teaching. It has to be skills development. It has to be community capacity, because information is everywhere now, and information didn't used to be everywhere before. So what is that unique role for public health to have? And we also recognize that CBT training should really be made more available outside the scope of just this limited margin of moms with postpartum depression, but taking it and broadening it to, other programs and services throughout public health, but exploring what might this look like if it became available for different populations that we serve here in Niagara or as public health as an agency.
Thanks, Christina. And Ryan, for setting us up so well for success and to bring us to what I'm proud to say are our next steps and continued work together. So, with our understanding of the impact that we can have and the feasibility of public health nurses delivering cognitive behavioral therapy for postpartum depression, and looking at our need in Niagara, through some of our available data, results of a parenting survey we've done, and even some other surveys since COVID, we really thought and found value in integrating the cognitive behavioral therapy group intervention into our regular reproductive and child health programming. It was in alignment with the Healthy Growth and Development Standard of the Ontario Public Health Standards. And we had good support and buy-in from our senior leadership team and, in alignment with our strategic direction to improve health and health equity in Niagara Region. I'll tell you a bit more about our integration into regular programming on the next slide, but it will result in some additional public health nurses to be trained to deliver the groups. We've also been fortunate to work with Ryan to adapt the intervention for some further at-risk clients, young moms in particular, who are accessing a program in Niagara called Strive, which is one of our key partners, and they provide access to secondary school for young moms in a bit of an alternative setting. So we've been able to look at how that intervention could be adapted for that population, seek Ryan's expertise to make some changes to the curriculum that are, meaningful for that clientele, and do a bit of a study there. And happy to say that we're continuing that work in partnership with Strive Niagara. We also have a new study underway. So we are now able to work with Ryan and his team to study public health nurse delivery of a one-day cognitive behavioral therapy psychoeducation workshop. So we've just launched into some pilot workshops now, and we hope we'll be able to share some results from that study with you all at another time. And in addition, through this partnership that we have, we've been able to expand training to be able to deliver some applied skills-based training to all of our public health nurses working with clients across a number of programs, including our home visiting programs, Healthy Babies, Healthy Children, Nurse Family Partnership, and some of the other programs we offer through reproductive and child health. We're also considering applicability and feasibility for school health nurses to be skilled up in some of the cognitive behavioral therapy skills. This training focused on the basics of cognitive behavioral therapy, handling client resistance, and working with more challenging and complex clients. So translating research to practice for us as we concluded the RCT really involved a number of steps. And for some context, we were considering this integration in the midst of the pandemic. So we had limited resources. We, had identified that continuing to deliver cognitive behavioral therapy for postpartum depression would be an essential service, recognizing, I think, some increasing need and risk for birthing parents during the pandemic. And so we needed to quickly present some evidence of the impact and need to our decision makers and senior leadership tables. And thankfully, there was a great deal of buy-in from our leaders. We did some consultation and continue to consult with Ryan and the research team regularly about our delivery of this intervention in practice. And we had to really establish our local delivery, which included looking at the eligibility criteria. Was there anything we would change? So we have included prenatal mothers and birthing parents in our launched intervention. We had to look at our registration processes, what kind of promotional needs we would have, and develop some procedures related to the delivery and follow-up. We also had to look at materials and develop an ongoing CQI, continuous quality improvement evaluation plan. So we really did a bit of a soft launch in September 2021. And the nurses, we had 5 nurses, trained nurse facilitators with us at that time who had not been impacted by redeployments and were working with us in business continuity. We worked so diligently, meeting very regularly to plan for this launch in September 2021. Despite it being a soft launch, we had full groups right off the bat. And we do go through some ongoing revisions to procedures, ongoing consultation. We did start using Facebook ads to promote the intervention, and that's been very successful for us. And we're working on some local primary care engagement as another important referral source. So to date, we've been able to offer 3 full series. So 3 9-week series have been completed. We have 2 series in progress at the moment, and a number more planned for the remainder of 2022. The 43 unique participants have been able to access group-based cognitive behavioral therapy for postpartum depression delivered here in Niagara. And we've had a really high retention of clients throughout the series. So at this point, we have been offering since our launch virtually, and looking forward to some kind of hybrid as we plan for fall, where we can continue to offer virtual series and also offer in-person series and give clients a bit of choice in terms of the mode in which they would access psychotherapy. We did also introduce electronic registration to support, so participants can go on and register for the series at any hour of the day, whenever they really feel motivated or are able to do so. The eligibility is then assessed by a public health nurse, and all of the registrants are connected with community resources, whether they're deemed eligible for the group or not. And we've launched some evaluation surveys. So we will continue to monitor the success of our implementation through a pre and post surveys, which include the Edinburgh Depression Scale and some questions about their experience of the program overall. Our plan is at minimum to deliver 6 to 8 series per year in Niagara, and really decision making there is based on our capacity and available resources in amongst our other programming that we offer. So I'm going to pass things back to Ryan for a few comments in summary. I think we'll try to get through the summary quickly so we have some time for your questions.
Thanks, Amanda. So, just to summarize the results of our collaboration and partnership, public health nurses with little to no prior psychiatric training can deliver effective group CBT for postpartum depression to improve depression, anxiety, and the mother-infant relationship. We were very excited to see that the benefits of CBT training extended beyond the groups to the other professional roles that the public health nurses have in their personal lives. And we're so excited that Amanda and leadership at Public Health in Niagara Region have started to use the same intervention in their usual practice. So we're very excited, that we think that public health nurse delivered group CBT for postpartum depression can increase access, reduce wait lists. We think it can be scaled. We know it can be delivered online. We did a sister study to the one we've just presented. We analyzed the data this week. We're going to write the paper up in the summer, I think there's nothing that we found there that would change your opinion about what you saw today.
And we have had some media, attention and awareness raising opportunities that are worth just highlighting. Through this research partnership, we've been able to really, I think, heighten awareness in our community about need and the intervention itself. Just wanted to make a few comments, I think, about powerful partnerships. I think collaborations between public health practitioners and university researchers can really enhance practice and research, and we really think of it as a win-win.
And we found through our experience working together that having common goals and persevering despite challenges and obstacles has been really key to our success.
And also because we have this relationship, we have this open communication too. We've developed a community of practice for the practitioners of CBT, as which, sometimes we engage Ryan in that to help us with our reflective practice. And again, just really strengthening those little nuances that comes with adding psychotherapy as a skill set to the nursing profession.
So I think we can move to some questions if that's okay. And we've got our email addresses on here as well. If we don't have time to get through all the questions, you're welcome to email any of us in follow-up.
Thank you, Ryan, Amanda, and Christina. That was absolutely so interesting, and what a brilliant example of research to practice of an effective evidence-based intervention in this space. I know many people on this call understands we don't have so many, and this is such a beautiful example and an excellent presentation. So we do have a lot of questions, and I'm going to try to get to all of them, but again, you guys will have these slides available, and if you have any questions, you can email the presenters or myself, and I'm sure they'd be happy to answer. So firstly, could this be shifted to be delivered prenatally for those who are high risk?
I think this could easily be delivered prenatally. When you say high risk, I'm not sure if you're thinking as a preventive intervention or as a treatment intervention. So certainly it could be, I think, an effective treatment intervention, and Amanda and her team have expanded when they're doing it in real practice, they're accepting pregnant persons and those who have postpartum depression, in terms of treating those who exceed the EPDS cutoff of 10 or more.
Thank you. Have the PHNs used CBT with their individual clients also, like one-on-one?
So I would say that we don't necessarily like sit down with them and do psychotherapy like as scheduled appointments. Like our role is not to do that one-on-one, be that individual counselor, but taking concepts that we've learned and helping navigate kind of their mental health, right? So, you know, recognizing where are they on their EPDS score, right? Like recognizing that postpartum depression is more on a spectrum, and what are the, you know, resources and services that would best suit that individuals. We might bring then in some CBT concepts and work with that in collaboration with primary care. You know, so you know, I wouldn't say that we sit down with them and say, okay, let's meet weekly and do something. But I know that within my practice as a lactation consultant, a lot of the core concepts are kind of brought in. And so a portion of our time together might be seeing how things are going and whether or not, you know, they need to pursue possible like pharmacological intervention, or, you know, would they be suited for group therapy, and, you know, make sure that they have access to the upcoming program and see whether or not that's a fit for them. I hope that answers that question.
Yeah, great, thank you. So I'm going to combine two questions about kind of next steps in training. What are your next steps regarding training for PHNs and other PHUs, particularly offering the 3 stages as described by Christina, including supervision and reflective practice? And could PHNs already trained be involved in a train the trainer model for the rest of us PHNs? I'm guessing it's from PHN, another local public health.
Yeah, so I mean, people would have to demonstrate, public health units would have to demonstrate an interest in learning about doing that, and we could certainly have those discussions. In terms of the train the trainer model, I have a parallel study where we've trained peers who've recovered from postpartum depression to deliver a similar intervention, and I spent part of the winter developing some materials so that they could then provide feedback to each other instead of psychotherapy supervision delivered by me. So we've been thinking about that, and I don't think there's any reason why that couldn't be scaled to public health nurses.
Similar question along the lines of training. Interested in hearing about the design of the CBT training and who implemented it, and is it widely available?
So Christina presented a slide on that. Basically, we have pre-training readings. We now do 2 days of in-classroom training, about 8 hours a day, 2 days, and then people watch a group delivered by sort of experts. In Niagara Region, that's been groups delivered by the experienced public health nurses. Sorry, Christina. And then usually we would supervise each pair once. So we'd watch them and give them supervision, and then they're on their own. That's what we did in the study. The public health nurses got 1 round of supervision each, and then they were off delivering it without any kind of like oversight. But now that we've created some checklists to help with fidelity assessment, like I think it would be fine.
Excellent. What are your thoughts on collaboration between a local public health organization and a community mental health support organization, for example, CMHA, in order to capitalize on skills and serve more community members? Do you see this being feasible or helpful?
I mean, those partnerships, I think, you know, would always be valuable to collaborate. And I think you'll find organizations that are working towards common objectives. So that was part of the success of our partnership is, you know, we're working toward the same goals and have, you know, like interests and can both benefit in some way from the collaboration. So I think that's really key to the success of it. Are you, you know, working towards the same objectives? And is there a benefit to each organization to be involved? So I think just assessing that, regardless of who the partner organization might be, certainly exploring mental health programs and organizations would make big sense.
Thanks. And the questions are flying in. So this is a great indication that this is on top of mind for many people, I think, across the province. So in that vein, can you comment on scalability beyond Niagara Health Unit? Is ongoing qualified clinical supervision required? Where do we find Orion in other communities?
You don't want to find Orion in other communities. You'd be glad that he's sort of like landlocked down here in Caledonia. But I think I think that it's scalable. I think that more people can be trained, and I think the train the trainer model is the way of the future. We'll have to see how the peers do in terms of like providing feedback / supervision to each other. I think it should be a success. We've automated as much of it as we could, made it sort of reproducible and things like that. We're just testing that out now. But I think hopefully scalable if there's interest.
So how did you access PHN staffing? Was there new funding or giving up other work?
Yeah, great question. There was not new funding. We really had to find, resource within existing program budgets. So these are cost share administrative health long-term care funded positions in the reproductive and child health program in Niagara, which really serves to meet the healthy growth and development standard. And so we had, we've had to prioritize in terms of the needs in our community. We focus a lot of our work on from prenatal, infant feeding, postpartum, mental health, and and parenting as our priority areas to focus on. I think there's a lot more that we could focus on in healthy growth and development, but really looking at need and looking at availability in our community of resources related to postpartum depression. So there's not really a lot of accessible, affordable interventions that are non-pharmacological that are available in Niagara. So there was a gap to fill, there was a need, and so we did prioritize in our general programs this work as an intervention that public health would offer.
Great, thank you. So what client feedback did you receive regarding the virtual series? And I'm going to give you opportunity to talk about how that's gone since the pandemic. Did clients receive similar clinical improvements? And were clients as receptive to the virtual format, i.e. high retention?
I imagine Ryan will want to speak to some of that, and likely Christina as well in terms of the client feedback.
Yeah, I can't tell you all the results of the study yet because we haven't published them, but I think, like I hinted at a few minutes ago, I think there's no reason to think that the effectiveness was less. Retention was a little better online. We had a lot more interest online, but that may have been pandemic related. People were, in more distress and so forth. So I think that it went well. I haven't looked at all of the individual comments that we've gotten back yet. That's sort of like the second level of looking at it. People were generally pleased. I mean, some found it challenging to do it in their home. Some found it challenging without extra childcare. So I think there were, some people really liked it and some people didn't like it as much. But we did what we just did what we could. Yeah.
Little things that kind of help with the option of a virtual series is if a family member or the participant themselves were unwell, they could still attend, right? So unlike having to attend in person or arrange for childcare, parents were caring, which for their children during the series. So again, there's some pros and cons that come with that. But typically we also had clients that just weren't feeling well, but because it was in a virtual format, their attendance continued. It wasn't a barrier.
Great, thank you. And can you comment on the cost of the 3-day training program? And I guess cost overall to the health unit if they were to take this up?
Yeah, that's maybe a conversation that's better had offline, and there are different nuances that I think we'd have to sort out in terms of number of nurses to be trained, especially since the supervision element is two at a time. So it's a good question. I just don't have the answer to it. Yeah.
This is one for the public health nurses. How did you handle charting for the group?
So we chart an electronic medical record and we chart it as group. So because it is that group chart, we chart their attendance and we chart that they were taught that curriculum for that module for that week. And then any like kind of discrepancies with that, we'd make a notation of that. So that gets reflected back into their individual client record that they attended and what information they received on that day.
Thank you so much. So I see we're just at time. So as we wrap up today's PHO round session, I'd like to thank Dr. Ryan Van Lieshout, Amanda Hicks, and Christina Bradley for presenting on such a really interesting and important topic. I'd like to thank everyone who joined us for today's session. It's great to see such strong virtual participation during such a challenging time for healthcare workers and professionals. You can expect to receive the brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.